الو، السلام عليكم. بسم الله الرحمن الرحيم. مرحب بكم شباب في الحلقة الثانية من برنامجنا هنا في سابا بتاع الانترنال ميديسن ريفيو. زي المرة اللي فاتت حندي شوية دقائق لأخواننا اللي اتأخروا شوية على أساس إنه يقدروا يبدوا معانا، ونحن بنعتذر عن التأخير لمدة دقيقتين اللي حصل في البداية، بس عشان قاعدين نحاول ننقل يوتيوب لايف برضو على أساس إنه الشباب اللي قالوا إنه في difficulties إنه يدخلوا عن طريق الزوم بسبب مشاكل الانترنت وكده. حاولنا برضو تو اكوموديت، فلو سمحتوا بس واحد فيكم ياكد لي انه انتوا سامعيني كويس. طيب، بسم الله الرحمن الرحيم. I would like to welcome everybody to the Sudanese American Physician Association Internal Medicine Review Series. Today will be our second lecture. Last week we had aortic emergencies, and today we'll be discussing heart failure. I would just like to highlight that we are uploading those lectures after we are done in the Sudanese American Physician Association YouTube channel, so you can go back to it. And we are sharing the PDFs through the Telegram group that we have shared in the social media in WhatsApp, so you can have access to the material itself. We send pre-registration survey and we send a post survey so we can evaluate our performance. And we hope to be able to continue those lectures every Saturday, 8 p.m. Khartoum time. So today our lecture is going to be about heart failure. So heart failure is defined as a complex clinical syndrome in which cardiac output is insufficient for meeting the demand of the body. The incidence of heart failure is estimated to be 23 million people having heart failure worldwide. Now, heart failure is, when I was in medical school, we used to learn that heart failure is divided in many different ways: forward, backward, left, right, systolic, diastolic. The current consensus is heart failure is divided mainly into two groups. The first group is heart failure with reduced ejection fraction, and that's with an ejection fraction less than 40%, equal to or less than 40%, and preserved ejection fraction, which is usually more than 40%. Now, of course, we're talking about left ventricular function predominantly. Now, I have a question for you guys is, judging by this definition, what would you think about the incidence and mortality rates between the two groups? Who do you think will have higher mortality? Who do you think will have higher incidence? Okay, we can type in the Q&A or in the chat function. Okay, so incidence is the same between the two groups, and symptoms are usually the same between the two groups as well. When we say right heart failure, we describe patients with peripheral congestion and with minimal to absence of pulmonary congestion. Now, we move along and we start talking next about the symptoms of heart failure. Now, we divided heart failure into two groups, but eventually we're gonna um, talk about them in general and then go into specifications. So symptoms of heart failure, mainly the main symptoms, if we remember the description, it's a problem with supply and demand essentially. So you have shortness of breath because of the fluid aggregation in the lung. You have exertional dyspnea, fatigue, paroxysmal nocturnal dyspnea, orthopnea, lower extremity edema. Um, Before we talk about heart failure, we have to establish few classifications or functional classes and diagnoses. So to start with, we're gonna talk first about the NYHA class, which is a functional assessment. So class 1 NYHA is patients with heart disease without limitation of physical activity. Class 2 are people who have limitations with a slight limitation with excessive physical activity. Class 3 are people who have shortness of breath with marked limitation to their physical activity. And class 4 are people who have symptoms at rest. So we're going to talk about this later, but it's very important to understand this classification and to be able to assess the patients accordingly. Okay. So next we go to the stages of development of heart failure. So stages of development of heart failure is essentially, first we have stage A. In stage A, those are people who are at risk of heart failure, but do not have structural heart disease or symptoms of heart failure. And those are people who have diabetes, hypertension, obesity, family history, or cardiomyopathy. Stage B are people who have developed structural heart disease, but without signs or symptoms of heart failure. And this stage includes patients who have NYHA functional class 1 with no prior or current symptoms or signs of heart failure. Perfect example will be people who have previous MIs or asymptomatic valvular heart disease. Stage C, those are people who have structural heart disease with prior or current symptoms of heart failure. And this stage includes patients with any NYHA class. Those are an example, patients with non-structural heart disease and heart failure symptoms and signs. Now, stage D, those unfortunately are the patients with refractory heart failure requiring specialized intervention. And this stage includes patients with NYHA functional class 4 and with refractory heart failure. Those are our patients who have been on treatment and despite that are going in and out of the hospitals. And those patients are the candidates for long-term ionotropic therapy or management with advanced mechanical support devices. Now, the reason this classification is important and we always keep talking about it is once you go to a stage, it's very difficult to reverse it and go back. So you want to catch your patients early on in stage 1, 2, 3, or so for stage A, B, C, and D, and try to identify them. If they're in stage A, try to prevent them from going to B. If they're in B, try to prevent them from going to C, and so forth. Pathophysiology is just a quick overview. So it's a bifid cycle. You have myocyte hypertrophy leading to fibrosis, leading to apoptosis, then necrosis, which leads to chamber enlargement. And once you reach the chamber enlargement, then you start having the symptoms and so forth. Now, this lecture series is mainly aimed towards diagnosis and management. And as we spoke earlier, this is mainly geared towards interns, general practitioners, registrars, even final year medical students, and some of the specialists who join us as well for updates. So we're going to spend some time talking about diagnosis and management. So diagnosis. In general in medicine, history is very important. Usually you reach your differential diagnosis by taking a good history, and you can even sort of narrow it down to 2 or 3 differential diagnoses. But in heart failure specifically, history is very, very important. You have to take your time, take detailed history. and be able to gauge the differential or have sort of an idea of what's going on with the patient just by the history. So a detailed history includes a good obstetrical history for females. You have to take family history. You have to take history of chemotherapy, alcohol, illicit drugs. Those are usually should be obtained. Now, the reason I highlighted those, because usually as internists, we don't tend to ask a lot about obstetrical history. Sometimes we don't go into details about, past history of cancers or chemotherapy. So we have to be very careful and take a lot of details from our patients. Uh, Traditionally, there are three symptoms that will tell you if the shortness of breath is mainly pulmonary or cardiac in component. You want to ask about paroxysmal nocturnal dyspnea, which is, as we all know, the patient typically describe the feeling as I wake up from sleep gasping for air. Some patients might say I go to the window to try to breathe because I can't breathe. This increases the likelihood of having heart failure by two folds. Orthopnea, which is typically described by the patients by the fact that they say, I used to sleep on one pillow, now I need 3 to 4 pillows to be able to sleep. And unfortunately, in very advanced cases, the patient might be sleeping, sitting up on his chair because he can't breathe. Lower extremity edema is another symptom that differentiates between heart failure and it differentiates between heart failure and pulmonary components. So other symptoms include dyspnea, abdominal discomfort. This can be due to hepatic congestion or ascites. We have fatigue, tiredness, and weakness, and those are mainly problems due to reduced cardiac output, and even mental confusion can ensue if the patient have a very low cardiac output. Now, examination. Examination, patient might look edematous, might be tachypnic, might be using his accessory muscles. Jugular venous distension is one of the major symptoms that can occur. You have bibasilar crackles. S3, S4 might be present on auscultation, and when present, those increase your likelihood by about 11 times or more. Lower extremity edema might occur. Then next we will talk. Just for a minute. Okay, so next we will talk about ascites and hepatomegaly, and then holosystolic murmur due to functional MR. So workup. Now workup, first we start by our CBC. We want to look for anemia. We want to look for infection as well, because it might be a clue to why the patient is having heart failure exacerbation. You want to look at your complete metabolic panel. Hyponatremia is usually associated with worse outcome. So another thing you want to look at is the potassium level, because you're going to diurese the patient. Now, when you're diuresing the patient, you want to keep an eye on the potassium, and you want to supplement aggressively, because people with structural heart disease are more likely to have ventricular arrhythmias, which is further exacerbated by electrolyte disturbances. Troponins can be elevated due to myocardial injury from heart failure itself, and in the same time, it can be an acute coronary syndrome, which by itself can cause heart failure or worsen heart failure. And thyroid function test is one of the paramount tests that we always send in cardiology in general, whether you have an arrhythmia, whether you have heart failure. You want to check your thyroid functions and make sure that there is no disturbances that need to be corrected and causing the underlying medical problem. Now, BNP. BNP, I gave it a whole slide because BNP has a lot of information involved. Now, traditionally, we use the beta-natriuretic peptide to aid in diagnosis of heart failure. Now, first we talk about screening. It is not recommended as a screening test for asymptomatic patients. The reason that this is very important is when we talked about the stages of development of heart failure, we said that stage A are people who are at risk, stage B who are people who have structural heart disease but asymptomatic. So yes, we want to prevent them from progressing, but BNP is not gonna guide that diagnosis plan and prevention plan. Now, the use of BNP in diagnosis, first of all, a value of less than 100 is usually 90%, has a 90% negative predictive value. So essentially, it means if your BNP is less than 100, the patient is unlikely to have heart failure. And usually, we try to look for alternatives. Few factors that might falsely increase the BNP level are advanced age, anemia, renal failure, and factors that might falsely decrease the value are obesity and pregnancy. Now, those two are very important, especially the factors that falsely decrease the value, like obesity and pregnancy, because they might mask the BNP level and then create a diagnostic dilemma for the treating physicians. Now, BNP is a substrate of neprilysin, and the value can not be accurately assessed in people taking angiotensin receptor blocker ARNI, which is called Interesto as a trade name. And in those patients, we use a new blood marker, which is called pro-BNP. Now, we're going to talk more about this medication later on in the presentation, but it's just something that I wanted to highlight, especially if you have a patient who's on those medications, come to you and complaining of shortness of breath, you find that the BNP level is out of whack, so it's not that diagnostic in those patients. As far as management, there is no evidence to support that serial measurement will lead to any mortality benefit or even hospitalization benefit in people who are admitted for heart failure. However, we found that establishing a level at discharge can be helpful for further assessment. Somebody is admitted to your hospital being treated for heart failure. On discharge, his BNP is 350. You know that the patient is walking, breathing comfortably, does not have marked edema anymore. So you know that this patient at this level is comfortable enough to go home. Now, patient comes to you next time to the emergency room after 2 months complaining of shortness of breath and the BNP is 250. So we know that with 300 he was comfortable. Now with 250 he's having symptoms. It's unlikely to be heart failure. But again, it does not rule it out. However, it helps you, gauge the patient problems. Second thing is there is a utility of using BNP in clinic post-discharge, because you want to see that you discharge the patient with BNP of 350 and the patient saying, you know what, I'm having some shortness of breath. So a measurement of BNP can be useful to tell you how to proceed further with his management and see if you need to give more diuresis as outpatient to avoid hospitalization and so forth. Okay, so in the Q&A section down, please, I would like you guys to comment and tell me what you see in this X-ray. Yes, 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 yes. So that's excellent. So I'm getting that we see pulmonary edema, and that's true. Now, usually we will see a bigger heart than this, but we are seeing clearly that there is pulmonary edema. Now, a nice streak, look at those tiny streaks that are going up. I'm sorry. So this is what we call cephalization of the blood vessels. You see that the blood vessels are engorged and they're going up towards the head. Now, usually, even if you see some vascular congestion, it will be towards the hilum of the lung. You're not going to see much of the blood vessel in the periphery, and you're not going to see those vessels as prominent going up to the head. Okay, so some other tests that are really important. ECG should be obtained on every patient who comes in with heart failure, and it shows you evidence of chamber enlargement, ischemia, conduction abnormalities, arrhythmias. Clues to specific diagnosis will be low voltage, which could be a marker of cardiac amyloidosis, especially if the patient is not obese, does not have pericardial effusion. Chest X-ray shows you the heart size, the effusion, and the congestion. But please just make sure that you review what type of chest X-ray the patient got. We all know that the heart size can be slightly larger than normal in people who got anterior posterior X-ray in opposition to the standard PA X-ray that we get for our patients. Echocardiography is important in diagnosis and sort of important in management as well. Usually, we need to know the ejection fraction, the chamber sizes, the diastolic function. In the same time, we need to follow the progression of the disease. So usually we follow those patients with serial echoes, depending on their clinical situation, every 3 months, every 6 months, every year. It depends how long you have been treating the patient and how is his clinical course. Next, those are specific tests. So remember, first we spoke about tests that everybody is going to have. Now, those are tests that are very specific to clinical scenarios. If you have somebody um, who is young, who is having diabetes, who is having heart failure, some skin color changes, those are people that you're going to suspect that they have, especially if they have liver derangement, that they have hemochromatosis. So iron profile can be of benefit, especially iron saturation. Cardiac MRI is used for infiltrative diseases like sarcoid and amyloid. Nuclear imaging, such as technetium pyrophosphate scan, is also useful in the wild type of amyloid. And then myocardial biopsy, which is an aggressive procedure, invasive procedure, but it's needed in certain situations like eosinophilic myocarditis. Now, heart failure with reduced ejection fraction. Now we're going to get a little bit more specific and detailed, and I believe this is the section that everybody will be waiting for, which involves the management and the approach and so forth. Causes of heart failure: ischemic heart disease is one of the leading causes. Hypertension. It was number one, but after management updates and more strict control, it became number two. Idiopathic valvular heart disease, myocarditis, drugs, thyroid disorders, HIV. Persistent tachyarrhythmias is important, especially if your patient have heart failure and you do an EKG, you find that they have AFib or they're known to have atrial fibrillation or atrial flutter, and then they come to you with symptoms of heart failure. We have an entity called tachycardia-mediated cardiomyopathy, which is usually reversible with the control of the arrhythmia itself. So that's why it's very important to highlight this type of heart failure. Autoimmune diseases and muscular dystrophies are known to cause it. And finally, we have medications. Now, medications, we have our chemotherapy agent, doxorubicin, trastuzumab, and cyclophosphamide. So out of doxycycline and trastuzumab, which is a famous board question here in the United States, which one do you think will cause irreversible cardiomyopathy, the doxorubicin or the trastuzumab? You guys can write in the chat function and we will see the answers. What do you guys think? Yes, true. So we're getting answers coming in. So that's true. Doxorubicin causes irreversible cardiomyopathy, and it's, as we know, it's a chemotherapeutic agent for people or patients with breast cancer. So doxorubicin cardiotoxicity, few highlights. First of all, it's dose dependent. If you give any dose more than 400, usually patient will develop cardiotoxicity. And it have a calculation with cumulative dose as well. So it depends how much you get per dose and how much doses you get in total. Trastuzumab can be reversible on the other hand. Now, this is an important slide. This is how we're going to manage our systolic heart failure patients as inpatient. We always go by our ABC, as our colleagues in emergency medicine always do. Make sure that the airway is patent. Make sure your patient is breathing well. If they're not, try to maintain their oxygen above 94%. Non-invasive ventilation such as CPAP and BiPAP can be very helpful in those patients. You want to start intravenous diuretics sooner than later. General measures, you want to restrict their salt intake less than 3 grams, the Europeans say less than 6. Fluid restriction 800 to 1 liter a day. Strict input and output monitoring, strict weight monitoring, monitor renal function, electrolytes, and smoking cessation. Now, the reason I put the input and output and the weight monitoring initially, because this is how you're gonna know if your diuretics are working or not. And these measures need collaboration from the patients, their families, and from the medical staff. So Every patient with heart failure who's admitted, you have to tell them strictly that they can drink 800 mLs to 1 liter a day, including any liquids they take during the day: soup, tea, coffee, soda. All of that is calculated into 1 liter a day. Input and output monitoring. Now, not every patient is gonna have a Foley, so you want them to make sure that they record the amount of urine they put out, and they let the nurse or the doctor know, so we have an accurate assessment of their net balance during the day. What is their input, output, and what is the net balance? Other thing is you want to do weight monitoring. Now, in this area, cardiology overlaps with nephrology, because in nephrology, in dialysis patients, we have a term dry weight. In cardiology also, we have the dry weight. Is the patients, if they have heart failure for a long time, they know that their weight usually, let's say, is 76 kilograms. And now they're coming to you with 85. So you know they're overloaded, and there's a lot of diuresis that needs to take place. Now, second thing is, from admission, you have to try to identify the reason for exacerbation. You want to know, why is the patient coming to you this time with exacerbation? Is he missing his medication? Is she taking too much fluids? Is the patient having an acute myocardial infarction? Is there new arrhythmias due to the structural heart disease? Is he suffering from infections? Is there pulmonary embolism? Blood pressure is uncontrolled, and so forth. Now, vasodilators, they are not used routinely and should be used in case-by-case basis. There is no mortality benefit shown in generalized use. We divide them into arterial dilators and venodilators. Now, vasodilators that works mainly in the arteries is nitroprusside, and we tend to use it in people with hypertensive emergencies. Those patients can benefit from intravenous infusion. They need aggressive hemodynamic monitoring, because the main side effect obviously is hypotension. It is metabolized to cyanide, so we cannot, it is metabolized into cyanide, so we cannot give it continuously, and it causes reflex tachycardia. Nitroglycerin infusion can be used to decrease venous tone in patients who are refractory to diuretics. Now, nitroglycerin, whether oral or IV, have the pitfall of having headache, hypotension, and dizziness. It causes tachyphylaxis. So after 24 to 48 hours, the body sort of gets used to it, so you don't get the same exact effect. And it should not be used with PDE5 inhibitor. The phosphodiesterase inhibitors are mainly Viagra. So especially in your male patients, you have to make sure you ask them clearly if they're taking any Viagra, because you cannot give the nitrate and the Viagra together. It will lead to severe hypotension and can lead to death. Now, diuretics. Diuretics, we divide patients into diuretic naive and diuretic experienced. Diuretic naive is your patient who comes first time with heart failure. Never ever before have been any diuretics. Those patients tend to be very sensitive and respond well to diuresis. So all what you need is 20 to 40 milligram of IV furosemide or Lasix. People who are experienced, people who are taking Lasix at home, you want to ask them first, how much Lasix are they taking? Let's say a patient is taking 40 milligram of Lasix twice a day. So you at minimum, you have to start with the same equivalent home dose, but intravenously. And the reason that we're going to start intravenously with the same dose is, when you give the diuretic intravenously, it have an immediate venodilatation effect, and it has 100% bioavailability, more or less. So you have to start by the home dose, or give more than it at least. You have to monitor your patient clinically and adjust the dose. Aim for weight reduction and net negative balance of at least -1 liter a day. And as we said earlier, you have to monitor electrolyte and renal function, and supplement potassium and magnesium aggressively, as it can predispose to arrhythmias. Now, there was a debate about bolus versus continuous infusion, and there was no clear difference. The dose trial examined it, and they tried to look at what can we do. So in the meta-analysis done earlier in London in 2014, they tested 10 trials, and they tried to see if there is any mortality benefit, and there was none documented. They followed up weight. You follow up your patients by weight, symptoms, physical exam, urine output, renal function, oxygenation. If the patient is in a critical care unit, You can use their CVP monitor if you have a central line, or you can use your ultrasound or echo machine to assess the IVC diameter. Now, one thing I want to highlight about bolus versus continuous infusion. When you give a diuretic intravenously, usually it starts working within 30 minutes to 1 hour and keeps working for roughly about 3 to 4 hours. When you're giving it as infusion, you have a steady state situation where the patient is having more or less the same dose of the diuretic continuously, which leads to good urine output. However, as we said, by research, there wasn't a clear difference in urine output and renal function. You have to wait on case-to-case basis, see if your patient have some element of chronic kidney disease and you believe that his kidneys are not sensitive enough to the diuretic, you prefer to give intravenous continuous infusion, that's also an acceptable alternative. Now, this is a very, very important slide. And if you're going to go home with anything from this lecture, this is the slide that you want to learn from today. Okay, so I have a question about if the patient is hypotensive and resistant to diuretics. So if the patient is hypotensive and resistant to diuretics, he will be going more towards heart cardiogenic shock, more or less, and those patients will need either a challenge with ionotrope, we can do continuous veno-venous hemodialysis, we can try to give them dobutamine and milrinone to jumpstart their kidneys and so forth. I think for now we're trying to discuss, like you're more or less hemodynamically stable patients, because cardiogenic shock will need a dedicated lecture. But one thing that's very important that's brought by this question is generally we tend to weigh hypotension. We allow a little bit of a lower blood pressure, but you don't want it to be too low to start having perfusion problem with the kidneys and develop acute kidney injury and so forth. So the pearls from this lecture, first we're going to start talking about, you have to remember that when your patient have heart failure, they might have gut edema, which decreases the absorption. Now, Lasix in general have 50% bioavailability when you take it orally. And when you add to that gut edema, the absorption of oral Lasix is going to be very low. That's why it's a BIFID cycle. Once the patient starts going into that heart failure and they start developing the gut edema, they're taking the Lasix thinking that it's working, but it's not. There is other alternative medication like torsemide and bumetanide, and they can be used inpatient or outpatient, but they are more reliable as far as oral management. Just a disclaimer, bumetanide is 1 milligram of bumetanide is more or less equal to 40 milligrams of Lasix, and torsemide, every 1 milligram is twice as strong as Lasix. So usually we say 1 milligram of bumetanide is equal to 20 of torsemide is equal to 40 of Lasix. So second thing is you have to remember to order your diuretics BID, not Q12 hours. This is a very important point. It makes a lot of difference in your patient's life. They want to go to sleep. If we're giving drip or we're giving 3 times a day dosing, then usually your patient will need a catheter. If you're giving it Q12, means the second dose is at 9 p.m. So the patient will keep going to the bathroom until 3 a.m. and then get a morning dose. So it's very cumbersome for the patient. So we recommend that we give it about 8 or 9 a.m. and 4 p.m. The other thing is we want to diurese, not give diuretics. Now, this is a very important point in management, is usually there is sort of physician comfort when we're giving Lasix 80 twice a day. We feel it's a good hefty dose, but our aim is to get a net negative balance of 1 liter a day. So if I'm giving a hefty dose, but the patient is not diuresing enough, then clinically he's not going to have the good outcome that we're looking for. So we always have to remember that we want to diurese, not give diuretics. Make sure to differentiate between cardiorenal syndrome, which needs more diuresis, and over diuresis. So essentially what happens is when you're having heart failure, you have poor perfusion to the kidneys. So you start having renal failure. Now you have decreased effective arterial pressure as well. When you start diuresing their patients, usually their kidneys start working well, their creatinine goes down, and so forth. Now, on the other entity, on the other hand, is that you have overdiuresis. You're giving too much diuretics, you're causing renal toxicity. Now, If you look at the next point, we're talking about plasma refill rate. When we're diuresing the intravascular compartment, and the fluid is in the intravascular and the interstitium. That's why you have the body edema, the anasarca, and so forth. So you have to remember that you have to give the body time to shift that fluid from the interstitium to the intravascular compartment. Now, generally, when we're looking at those patients, we say that if they come in the first 1 or 2 days and their renal function, the patient comes to you with acute kidney injury and the renal function is getting worse. This tells you that the patient have most likely cardiorenal syndrome, especially if there is no good urine output, and it tells you need to be more aggressive. On the other hand, if somebody have been diuresed for 3 4 days, usually diuretics reach a steady state within 24 to 48 hours. So if I'm giving you Lasix ATBID, for example, for 48 hours, you don't have marked electrolyte derangement, your kidney function has been normal, it's unlikely that this same dose will cause any further problem in your electrolytes by itself unless you develop dehydration, and then you will have AKI. So again, those tie up nicely to the clinical examination and evaluation. If somebody is becoming dry clinically, not orthopnic anymore, does not require supplemental oxygen, walking around comfortably, had an increase in creatinine, that is most likely overdiuresis. While the other patient who comes in with shortness of breath that did not get better, the weight did not change much, renal function is getting deranged, those are patients that more likely have cardiorenal syndrome and need more diuresis. Remember to add spironolactone when you can. Remind your patient about fluid restriction every single day, because uh, you're used to drinking substantial amount of fluid every day in your life, and all of a sudden you are told that you have to restrict the amount of fluid you're taking. So that by human nature, we always try to play around the rules. So patients sometimes don't count tea or coffee or soda into the fluid restriction. If BUN goes up slightly, it's okay to keep diuresing. But if your renal function worsens after a few days of diuresis, consider a diuresis holiday or vacation. So if the renal function is okay, but the BUN is going up slightly, as we said, we can continue. If it's going more, it can tell you that you're not giving enough time for the plasma refill, so you can slow down in the diuresis. If you're giving 40 twice a day, maybe make it once a day, or give the patient 24 hours without any diuretic, allow for some fluid readjustment to happen in the body. We have to balance the diuresis to the blood pressure and starting ACE or ARB. And do not forget ischemia evaluation. And that's very important, not to forget any ischemia evaluation. We will allow some time for the questions. I see that we have some questions. So if you guys have any questions, please type them in the Q&A section. Okay. Okay. So question number one that I have right now is about calcium channel blockers. So calcium channel blockers should not be used in people with systolic heart failure. They lead to increased mortality. Now, if we look back at people, at normal physiology of the heart, you have your myocyte, which has the beta cells, and inside the beta cells, the ATP works on the calcium activated calcium channels. When you give calcium channel blockers, you are causing negative ionotropy, negative chronotropy, and in fact, all research have pointed to increased mortality with calcium channel blockers. So it's class C. It should not be used with people with ejection fraction less than 35%. Uh, Pitfalls of using midodrine in people with heart failure and soft blood pressure. That's a very good question, yeah, Ashraf. Uh, Midodrine leads essentially to vasoconstriction, and vasoconstriction will lead to increase afterload. Now, remember, we're talking about heart failure. We have preload issues, we have afterload issues, and we have the pump issues. So when you're giving midodrine, you can run into afterload issues, and we're going to talk about the afterload reduction actually as part of the algorithm of management of heart failure. There is another good question about beta blocker and decompensated heart failure. Now, we're gonna come to beta blockers in management of heart failure in details, but as a general rule of thumb, we do not start beta blockers in somebody who's newly diagnosed with heart failure. We start it after the exacerbation is gone. However, the research shows that if somebody have already been on a beta blocker, you can continue the same dose they're taking at home. And once they're recovered, we will talk later on about how to adjust it and so forth. Ahmed Ali is asking about ICD, and we're gonna talk about ICD in detail. Actually, we have a dedicated slide about ICDs and so forth. We have another question about heart failure and afterload and uh, pleural effusion, develop fluid loss like diarrhea. Would you? Oh, okay, about fluid replacement. So essentially, those patients have enough fluid in their system. You don't need to start giving them more fluid. What we do usually is, if the patient is having significant AKI, we can give them back slow amount of fluid, maybe 250 cc's as a bolus, or slow infusion for 10 hours of about 50 to 100 cc's, and see how they do with it. But generally speaking, if we're diuresing carefully and appropriately, we should not run into major problems. I think now the questions are going more towards next step of management. So why don't we continue? And some of those questions will already be answered in the next step of the presentation. So chronic medical management of heart failure with reduced ejection fraction. Beta blockers. So as you see in the right here, we have mortality benefit. We try to add the medications as tolerated. We do not start them in acute exacerbation. But if the patient was on beta blocker, it's safe to continue the same dose he was taking at home. Uh, Beta blockers that are studied are metoprolol, succinate, carvedilol, and bisoprolol. Now, the metoprolol that's given twice a day is tartrate, which has not been studied as far as heart failure patients are concerned. So if I'm picking beta blockers, it's going to be by usually one of those three, because those are one proven by research. We aim for a heart rate of 60. We titrate up as much as we can, and we're talking about people who are stable. We don't want to start titrating inpatient when the patient is acutely ill. General rule of thumb is metoprolol usually give you more heart rate control than blood pressure control, and carvedilol gives you more blood pressure control than heart rate control. Our colleagues who are heart failure specialists tend to like carvedilol because it has alpha blockage, so it gives you some afterload reduction, it gives you beta blocker effect. If the patient can tolerate, carvedilol is a good idea. If not, we can always go with the metoprolol. ACE inhibitors and angiotensin receptor blockers. So always counsel your patients about angioedema, and I cannot highlight this enough. You don't want your patient to start having some lip swelling and just brush it away and continue taking the medication. Remember that cough is more with ACE inhibitor than ARBs. Start with low dose. Now, this is important for management of your patients. You want to start with lowest dose possible, depending on the blood pressure and so forth. Now, you repeat a basic metabolic panel, looking for potassium, looking for creatinine, and you check the symptoms in 2 weeks. If the patient doesn't have angioedema, no severe cough that's interacting with his daily activity, then you may increase the dose and keep increasing and, until you reach the maximum dose possible. When it comes to ACE inhibitor and angiotensin receptor blockers, they help in cardiac remodeling, and it's very important to try to maximize the dose as much as possible. Last thing, remember that angioedema can happen at any time, but mainly in the first year. So if you don't have angioedema in the first month or two, it doesn't mean that it's not going to happen. So that's why we always said that you have to counsel your patients about the risk of angioedema. Now, I mentioned ACE and R because I believe this is the thing we have commonly in Sudan. There is a new entity called ARNI. ARNI is the scopotriol and valsartan, which is called trade name Entresto. It has been proven by research to be superior to ACE or ARB, but it causes more hypotension, it's more expensive, it's not widely available, and it interacts with your BNP assessment. In the United States, we use it often, we use it commonly. We try to put patients on it as much as possible. Now, mineralocorticoid receptor antagonist, also mortality benefit, and those are NYHA class 2 to 4. Any hospitalized patients should be on it post-discharge. It causes hyperkalemia, so it's good for people who develop hypokalemia in diuretics because you want to balance. Every patient who's admitted is gonna need to be on diuretics. So if the patient is running into hypokalemia with the Lasix or bumetanide or torsemide, it's good to have mineralocorticoids on board. they can cause gynecomastia. It's more spironolactone. Now, hydrolazine and nitrates, this ties to one of the questions about the use of midodrine. Now, research has proven that people who are not able to take ACE or R because of angioedema or intractable hyperkalemia, uh, hydrolazine and nitrates are an alternative for ACE or ARB. They're great for afterload reduction. Few things we have to remember: nitrates cause headache and dizziness. In clinical practice, we find out that usually, as we said earlier, there is sort of tachyphylaxis. So after a while, you don't feel the symptoms, but some people have very severe dizziness that they can't even function. Hydrolazine can cause lupus-like syndrome. Diuretics. Now, one thing to highlight, they have no mortality benefit, but they decrease hospitalization. Um, any patients who has been admitted with heart failure should be on diuretics based on his hospital dose. Now, remember in acute situation, we're over diuresing. So if you're diuresing somebody in the hospital and you're giving them 80 BID and they're putting out 4 or 5 liters a day, it's unlikely that they're going to need the same dose going home. Usually we'll try to cut back a little bit, but they should be on diuretics based on their on their hospital regimen. Usually, if we're starting as outpatient, we start by 20 to 40 milligram PO of Lasix. We follow up and adjust to the symptoms. We can teach our patients to monitor their weight, and we do that actually, especially in the summer months when people are sweating a lot and they feel very thirsty. You don't want them to dehydrate and have acute kidney injury because of the diuretics, and in the same time, you don't want them to be overloaded. So you can teach your patient to monitor their weight. And what we do is we tell our patients if they gain 1 to 2 kilograms in a day, then they will know that they are retaining fluid and they know to take an extra dose of the medication. So hypothetically, I have a patient who is taking 40 milligrams once a day. The patient find out that they gained 1 kilogram and they notice that they're getting a little bit short of breath. So then they will know to take another dose of 40 milligram at night for that day. Now, this is the question about implantable cardioverter defibrillators. They have mortality benefit, and the reason being is that people with structural heart disease are at high risk of ventricular arrhythmias, patients with EF less than 35%, and on optimal medical therapy. Now, I want to highlight this point. In United States, it's a very common question in the boards. I give you somebody who's in a small dose of metoprolol, small dose of ACE inhibitor, and I tell you that this patient comes to you today, EF is 35%, comes to you after 3 months, the EF is still 35%. What do you want to do? So the wrong answer would be ICD, because remember we said optimal medical therapy. It means you have to maximize your medication. When we spoke about ACE or ARB, we said that we have to increase as much as we can. Uh, those patients usually they have to be a window of 40 days after ischemic cardiomyopathy diagnosis or 90 days after non-ischemic cardiomyopathy diagnosis. Patient comes today, we start them on medication, follow them as outpatient, titrate up as much as we can, then repeat an echo in 40 days for ischemic, 90 days of non-ischemic. If there is no change, then those patients will warrant an implantable cardioverter defibrillator, and their QRS has to be less than 120 milliseconds. And this is for primary prevention of sudden cardiac death. Now, I just brought this picture so we have a small idea for those of us who have not dealt with patients with ICD. It's small device goes on the left upper part of the chest, and this wire is going inside their venous system into the right atrium and into the right ventricle. Uh, the few things, the difference between ICD and pacemaker, the pulse generator is bigger in the ICD, and the wire that's going into the ventricle is thick. So this device will sense all the time, and once it identifies any abnormal rhythms like VTAC or VFib, it will deliver a shock and save the patient's life. It also can function as a pacemaker if need be. So that's another benefit that you can have. If a patient develops heart block and he have this on, it will function as a pacemaker. Now, it's not an ideal pacemaker, and that's a different topic to discuss related to electrophysiology, but we just want to know that it can function as a pacemaker. It has a decent battery lifetime. The new ones can go up to 16 years if you're not using it as a pacemaker, just as an ICD. On the other hand, here we have something called subcutaneous pacemaker. The device here goes in the ICD goes in the left upper chest. The subcutaneous usually goes in the lateral side of the chest, and it's a little lower, maybe around the sixth, seventh, eighth ribs, and the wire goes from the outside surface of the heart. Now, subcutaneous ICDs, their advantage is you don't need vascular access. It's you can do it without fluoroscopy if you need, and it does not cause the same risk of infection as ICD because the ICD is going directly into the heart, so the risk of endocarditis is higher. And the disadvantage is you cannot use it as a pacemaker, essentially, like we said about the ICD. Cardiac resynchronization therapy has a mortality benefit. What is cardiac resynchronization therapy? Now, naturally, your left ventricle beats few milliseconds before your right ventricle. Once you have heart failure and your QRS is wide, you might have a situation where the ventricles are not coordinating well, and this leads to asynchrony. Asynchrony means the blood flow is not flowing as it should, and this leads to worsening heart failure. So the research have showed us that once we try to restore some of that normal synchrony to the heart, those patients tend to do well. Now, how do we select them? Same thing. Ejection fraction less than 35%, optimal medical therapy, same window period, QRS more than 120, and this will serve to restore the synchronization between the heart chambers. To put it into perspective, this is the device. You see it's the same place as the ICD in the left upper chest. You have three wires, one going into the atrium, one going into the right ventricle, and one goes through the outside through the coronary sinus, and it goes all the way to the left ventricle from the outside of the heart, not from inside. So the atrial lead will sense the atrial contractility and try to coordinate the ventricle contractility. Now, last thing, it's very short portion about heart failure with preserved ejection fraction. Causes are more or less similar, but mainly here hypertension, coronary artery disease, diabetes, amyloidosis, hemochromatosis, HOCM, and restrictive cardiomyopathy. Patient criteria, those are usually older, obese females with history of hypertension, CAD, or diabetes. Management, the inpatient management is the same. It's just diuretics. You have to be careful about how you diurese them. You don't need the vasodilators. You mainly need the diuretics. Some trial proposed mortality benefit with spironolactone. Chronic management is only beta blocker and spironolactone. We don't do the ACE, we don't do the ARB. There have been trials with them. Nothing has been proven to work. You don't do the hydralazine, the nitrate, none of that. If I'm going to leave you with one thing from this lecture, apart from the pearl slide, is going to be you have to bring any patient who has been admitted with heart failure. They should follow with the doctor within 7 days of discharge. This decreases their hospitalization. And this doctor does not have to be strictly their cardiologist. It can be the family physician. It can be the internal medicine physician. As long as they follow within 7 days post-discharge, they will do better and they will be able to titrate their medication and prevent further hospitalization. The reason being is that usually when we're discharging them, we give you IV medication and then we switch you to oral and we send you home. We don't know how you're going to react to that oral medication. So you want to follow within 1 week. Those are the references. And I think we can take some questions now. You can use the Q&A segment, and this will be it for this presentation for today. We try to highlight about CHF management. We did not talk much about cardiogenic shock because it will be a different topic of discussion. Okay, so we have a question about fluid management in DKA patient. Fluid management in DKA patient, usually DKA patients are intravascularly depleted. So actually you should give them fluid. You don't want to dehydrate them more because this will worsen the renal failure and it will put you in a problem as far as management. In a patient with hypertension and heart failure with preserved ejection fraction, what is the first choice of antihypertensive? With preserved ejection fraction, I will give them beta blockers and I will give them spironolactone. Any other questions, guys? We were hoping to have Dr. Yaqub. I don't know if Dr. Yaqub is available or not. Okay. Pathophysiology of HFpEF and HFrEF. Okay. So HFrEF is the reduced ejection fraction, is systolic heart failure. Those patients are usually um, people who have either ischemic heart disease or have structural problem that led to dilatation and then a problem with the ejection fraction function itself. HFpEF is usually relaxation problem. The heart is not relaxing as it should. Now, if we look at a cross-section of the anatomy of the heart of people with reduced ejection fraction, we find that their ventricle is enlarged and dilated. HFpEF, it might be normal size, the cavity might even be smaller. So with HFpEF, it's mainly relaxation problem. There is another great question about digoxin. That's a very nice question from you, Mahmoud. I think I omitted it in my discussion. Uh, people, people who have heart failure with reduced ejection fraction can benefit from digoxin. For the longest, we've always been considering digoxin as a great medication for heart failure. The only problem with it was the narrow therapeutic window and the fact that it leads to which usually presents with yellow vision, nausea, vomiting, and abdominal pain. But nowadays we have something called digibind, which is an agent that we use to reverse digoxin toxicity. There was a trial, I believe it was Jupiter trial, if I'm not mistaken, that said digoxin led to decreased hospitalization but increased mortality, which was an isolated trial. We still do use digoxin in clinical practice. We don't use it as the same way that we used to use it in the past when we load the patients and so forth. Now we give it in a small dose, maybe 0.125 twice a week. And patients can be on it. It's very useful. It's very helpful in people who have systolic heart failure. Digoxin, again, you have to be very careful about the signs of toxicity that we spoke about. You have to know that digoxin tends to have more toxicity in people who have renal failure, elderly, low weight, and females. So Sahar is asking about management of heart failure and renal impairment. So people who have stable CKD can get diuresis. Usually they require higher dose of diuresis. And usually they open, even if they develop acute and chronic kidney injury, they do open up with time and their kidneys tend to respond well. So the fact that you have chronic kidney injury does not preclude you from getting diuretics. It means you might need a little bit of a higher dose. Some of them might need infusion. Unfortunately, sometimes it might be a little bit too late and then they end up on dialysis. Dr. Ali Said is asking about medication combo recommended for heart failure less than 40%. So we spoke about those medications, but just to recap, the new recommendation last year from the meeting here in the East Coast in New York was they recommend giving as much medication as you can. Now, back in the day, we used to say maximize beta blocker, maximize ACE inhibitor, and then add more medication. But now we like to add as much medication as we can because you want to tackle heart failure from different point of views and pathophysiologies. Um, Amal is asking about role of Interesto. If Interesto is available in Sudan, it will be a great medication. It works very well with patients. And again, it might cause a little bit of hypotension, but just be careful, start it in a small dose and keep adding it up. Pro BNP is a good medication. It can be used absolutely. It's a good test, sorry. It can be used. It's mainly useful in people who are on Interesto because, as we said earlier in the discussion, BNP result can be false with Interesto, but I don't know if we have it in Sudan available. Okay. So heart transplant patients are patients. There's a nice question about heart transplant. Those are patients with class D. Those are your patients who have either very low ejection fraction or repeated hospitalizations. Uh, Heart transplant is a lengthy discussion, Muhammad, but just generally speaking, usually you want your heart transplant patient to be less than 70, no history of alcohol, no history of drug abuse, somebody who doesn't have profound mental issues that will prevent him from taking his medication, and to have good family support. There will be a detailed, evaluation. They have to see the renal function, the vessels, and so forth. But you can consider it in people who have class D heart failure, who have repeated hospitalizations and profoundly low ejection fraction. Um, what is the role between dilated cardiomyopathy and long-term CHF, and how can I prevent? So how can I prevent dilated cardiomyopathy? That's a very good question, yeah, Ahmed Suleiman. From what we said, now the current recommendation is you want to, those are your class A heart failure patient. Those are the people who are at risk. You want to prevent them from being class B. What do we do? If they have HIV, treat their HIV. If they have diabetes, maintain their A1C within good control of 7 or below. If they have blood pressure, you have to tightly manage their blood pressure. And the Joint National Committee of Heart Failure that does the guidelines for hypertension management here in the US, now they recommend 130 over 80 or 140 over 80 as a cutoff for your blood pressure, depending on the age and so forth. If you have any ischemia or chest pain, angina going on, you have to evaluate it early, treat it early. Idiopathic dilated cardiomyopathy, unfortunately, it's something familial. All what you can do is be on top of it early on, identify the patients, treat the patients. You have to screen some of them if there is strong family history, and start them on medication early on, I guess. One thing that I would mention that has not been discussed in this topic, because it's a broad topic that I'm not going to do it justice by just going in one slide about it, which is direct cardiomyopathy in the setting of pregnancy or peripartum cardiomyopathy. It's a very serious condition. It have higher mortality, and if any female develops direct cardiomyopathy, uh, peripartum, she should not get pregnant. Management of heart failure in COVID patients, yeah, hala, it's challenging because they tend to develop AKI more. We try to diuresis them in the COVID era, and it led to more renal injury. It's a sensitive issue. I think you need to be guided by your CVP monitor, or right heart cath will give you a good idea. Role of family physicians in follow-up of heart failure patients. Sana, that's a very excellent question. Role of family physicians is they are the first line of defense. The patient comes to you post-discharge and comes to you for follow-up. So you want to identify those patients. You want to have a strict treatment plan with them. You want to address their salt intake, their fluid intake, their medication list. You want to try to see if they're taking their medication, if they're having any side effect with it. You want to encourage them to have frequent visits with you because they have the strongest rapport with their family physicians. And you want to identify an exacerbation early, try to give them oral medication or admit them early if they need admission, rather than them coming to you late and requiring inotropic management or pressors. Ashraf is asking about AFib with RVR. So AFib with RVR with heart failure is 2 tiers. If you have hemodynamic instability, you want to shock them because the AFib is going to make the heart failure worse anyways. So you management of AFib with RVR with hemodynamic instability in general is shock. If you have your acute CHF and you're treating them, usually their AFib tends to get better. So it depends which came first, the chicken or the egg, honestly. Management of, there is no role of, okay, nitrates. It's not only for people who are hypertensive. It can be given for people who failed Lasix management or with severe pulmonary edema on presentation until they respond to Lasix. So yes, we can use it. Rate lowering agent in people, okay, people who have AFib who present to you and you need to control their heart rate. Again, with systolic heart failure, you cannot give them cardizem. You can give them digoxin, which is a good medication. IV, obviously, because oral takes a long time. So you can give them an IV load, which will help their heart failure, plus help in management of their rate control. Beta blocker, if they're not in fluid exacerbation, yes, you can give it. And amiodarone is a good medication. But amiodarone, you have to remember that you're chemically cardioverting them. So there is higher risk of stroke unless the patient is taking anticoagulation. If a patient is in digoxin, they need regular. Okay, so the question is, people on digoxin, do they need regular checkups for symptoms and sign of toxicity? In heart failure, what we're doing now in practice, we're not giving them substantial enough dose to warrant them for, to have toxicity. You always have to ask about signs of toxicity. You can do the blood test. We do the blood test, especially in the beginning, after the 4th dose, then 1 week after discharge. But the dose usually used is like 0.125 or 0.25 twice a week, which usually would not cause toxicity. Okay. What about metolazone? So metolazone is a very good medication. It's a strong loop diuretic. We give it as an adjunct medication. Metolazone is very effective. It leads to more AKI though because you're giving two loop diuretics together. We almost never give metolazone as the daily dose. Metolazone is given as a rescue medication for, we can give it on people who have repeated admissions or class C or D. We give them metolazone, 2 or 3 times a week, or you can give it as a rescue medication and tell the patient if you're gaining weight, we're going to give you an extra dose of metolazone that you can take to augment your urine output. Why is ICD never be used unless you maximize your medication? So ICD doesn't have adverse side effects per se. I mean, every procedure comes with side effect, obviously, and risk of endocarditis, plus cost, plus discomfort. But yeah, Asma, the thing is you don't want to put patients through invasive procedure, which has a risk of pericardial effusion, it have a risk of pneumothorax and so forth, unless you have to. We do see sometimes people who are maximizing their medication and their ejection fraction improve and they don't need the ICD altogether. Hyponatremia in heart failure, it's usually volemic hyponatremia, and those people usually will just need diuresis. Now, once you diurese them, usually their hyponatremia will tend to get better. Now, remember, hyponatremia is a poor prognostic sign in heart failure. And, with diuresis, we hope they improve. If they don't, it can be a sign that they're not being diuresed enough, and those are the people that might be candidate to inotropes and so forth. Ashraf, ionotropes, I think I would leave it to be a dedicated topic because it's a little bit more challenging. It will be an involved discussion about hemodynamics and so forth. So we'll leave it for another session. We have a question from Dr. Ali Said about, as a cardiologist, how would you say with 30 cc's per fluid bolus in septic shock with history of systolic heart failure? Honestly, this was a very interesting topic of discussion last year here in New York. The Joint Commission was cracking out in hospitals and asking for aggressive sepsis management. And we had a nice panel that they were talking about what do we do for people who come with severe sepsis. Now, when you come with severe sepsis, your intravascular space is depleted and we go with the fluid. We can always give you diuretic later on if you're overloaded. You have to follow your patients clinically, follow their CVP, their IVC with the ultrasound, their bibasilar crackles by examination. But the priority would be for hemodynamic stabilization. And yes, you can give them fluid if they need. Okay, so dapagliflozin, actually I was thinking about this topic. So dapagliflozin is one of the diabetes medication that was studied initially, and they found that it has good mortality benefit for people who are diabetics and with heart failure. And now the FDA actually has approved it even for people who do not have heart failure. The trade name, as we all know, it's Fraxiga, and I think if available, it can absolutely be used and it's a good medication. Isn't lowering heart rate worsening heart failure? No, actually, lowering heart rate will give you more time to fill your ventricle, improve your ejection fraction, and will give you more time to oxygenate your myocardium. So as we said, you don't want to lower heart rate initially with acute exacerbation, but you want to have low heart rate overall. Abdullah, I just want to comment another thing for Abdullah Faiz Abdullahi about the dapagliflozin, because it was a very nice question in addition to the topic. It's an SGLT2 inhibitor for those of us who are not familiar with it. Or what it does is it decreases your threshold for sugar excretion through the kidney tubules, but the cardiologists also studied it and they found it have a lot of effects on your renin-angiotensin system and your mineralocorticoid system. So it works by tackling more than one thing. We used to say that you should start the first dose in the hospital because when you're peeing out a lot of sugar, you tend to have electrolyte abnormalities. But from the last topic, at least I've attended, they were saying that this is no longer the situation. It have higher risk of fungal infection because you're excreting more sugar in the urine. So UTIs and fungal infection in the urine are common with it. Do we need to anticoagulate any admitted patient with heart failure? So Mathaba, we anticoagulate those who need anticoagulation, meaning that people who have very low AF are at risk of LV thrombus, so they should be anticoagulated if they have LV thrombus. If they have AFib, if they have a flutter, they should be anticoagulated. And if there is any clinical indication, heart failure by itself is not an indication, but full anticoagulation should be guided by clinical indications. That being said, you want to make sure that you're giving them DVT prophylaxis because those patients are not going to be walking a lot. Unfractionated heparin, 5,000 unit twice, 3 times a day, or you can give them, Clexane, low molecular weight heparin prophylaxis dose. Okay. Bromocriptine in postpartum cardiomyopathy, Abdullahi, I'm not honestly familiar with it that much because, it's more of a woman in cardiology topic, so I don't want to give you deceiving information. Heart failure and bronchial asthma. Oh, maybe this is a very nice question. So when we were students or even when we were interns, there's a very nice term which is called cardiac asthma. Cardiac asthma, they called it this name because they found out that back in the day, a lot of patients were coming to the emergency room saying they're short of breath, they don't have a lot of lower extremity edema because they're in the initial stages of their left heart failure. The right side have not been yet flooded that much for you to start seeing lower extremity edema, are getting labeled as asthma, given beta agonist, which leads to worsening heart failure because of the tachycardia. So that's why they called it cardiac asthma. So heart failure and bronchial asthma, I would really be careful about labeling somebody who have heart failure as a bronchial asthma attack until I absolutely exclude heart failure. Because both of them will come with shortness of breath, both of them will give you some sort of bronchi on exam, but heart failure will be more of crackles, so it needs an experienced person exam. So I would be weary about calling bronchial asthma immediately on heart failure until I do a thorough exam. Um, the role of doxazocine in preventing heart failure. Okay. Okay, so um, I think we have covered a lot of topics. Um, so I think we will call it a day for today, and we are gonna have a second round of heart failure, hopefully in the future, that we're gonna talk about advanced heart failure, hemodynamic monitoring, and so forth. And oh, Ashraf is right. I'm sorry. I think I might have made a mistake about metolazone. Did I say it's a loop? I think yeah, I said it's a loop. So it's a thiazide, not a loop, but it's an aggressive thiazide diuretic in conjunction with the loop. It leads to AKI. So I think we're gonna call it a day today, and we're gonna continue with the second lecture, hopefully in the future, talking about hemodynamic monitoring, cardiogenic shock, inotropic management, and bridge for transplant, and LVADs. Thank you guys very much, and thank you for participation in your SAPA activity, and we hope to see you next Saturday, inshallah. This lecture will be available to you guys on YouTube, and we will send you a PDF through our Telegram channel. And we will share with you our post survey, and we will share with you the topic of next Saturday. I believe it's going to be EKG one-on-one done by an electrophysiologist. Thank you guys for your participation.